Well, good morning, everyone, and welcome to the American Hospital Association Age-Friendly Health System webinar, Empowering Teams Through Trustee and C-Suite Leadership in Age-Friendly Care. I'm really excited about this morning. We have Hackensack Meridian Health with us today, and we've had the opportunity to work with these folks previously, and I think you're in for a really exciting morning. I'll start by introducing everyone. I guess I should start with myself. I'm Marie Clary Fishman. I'm the Vice President of Clinical Quality for Health Research and Education Trust, the not-for-profit arm of the American Hospital Association. So we'll start this morning by welcoming Dr. Jose Azar, MD. Jose, good morning. Jose,
hi, good morning, Marie.
Thank you. He's the Executive Vice President and Chief Quality Officer, Professor of Medicine at Hackensack Meridian School of Medicine, in the Department of Hematology, Oncology. We're really glad you're here, Jose. Thank you for joining us again. Your card of attendance for us has just been remarkable. So thank you for giving us all the time and your knowledge. Next, we're going to introduce Mr. Sean Reynolds. He's the chair of the HMH Hospital Corporation Board, and he will be with us today. And again, Sean, you're in such an amazing position, and thank you so much for participating with us and giving us your insight and the importance of leadership at the board level. So we really appreciate it. And we have Mary Jo Phillips. Mary Jo, a little bit delay in getting Mary Jo on the camera there, but we'll get her. She's the critical linchpin of our webinar today. So Mary Jo is the Network Clinical Program Manager of Geriatrics. And Mary Jo has also presented at our summit. There we go. There, Mary Jo with a great background. She's presented at the AHA Leadership Summit. And so we're really pleased and honored to have this group back with us today, and to be able to share the amazing work that they are doing at Hackensack Meridian Health. So, Mary Jo, I'm going to throw this over to you for a beginning overview of the work you're doing there, and share all of the really great things and the critical pieces we're going to talk about today as we go on further. So, Mary Jo, take it away.
Thanks, Marie. And thank you so much. Hackensack Meridian Health is really excited to be here this morning, so we appreciate you asking us. So as a nurse, I would be remiss if I did not start way back in 2012. Hackensack Meridian Health has been a proud site of nursing excellence for niche, so nurses improving care for healthcare elders. Ann Hendricks, we have actually always used her tool for fall prevention. And during the pandemic, back in 2019, Ann and I partnered together to actually automate the Hendricks Fall Risk Assessment in Epic. It's actually something that's available to everyone in their system. And the reason I'm pulling from this is when Ann and I were working on this, she looked at me and she said, Mary Jo, these are all the foundations of the 4 M's. You can apply to have all of your system be an age-friendly site. So that's what prompted me back then to apply to be age-friendly. Since then, we are also part of the Age-Friendly System-Wide Spread Collaborative. And then some of the other intersect that really brought on my Chief Quality Officer here, Jose, and our board, Sean, was really how we decided to leverage age-friendly with our Joint Commission Health Equity Certification, and then other priorities in the organization, like the Geriatric Surgical Verification Program and the Emergency Department Accreditation. So that's what got us here today. Jose or Sean, do you guys have anything to add to that?
Yes, I want to say the journey has been phenomenal. And, it was easy to spot Mary Jo and all her great work. I've been at Hackensack Meridian Health for about 3.5 years. And her work and the work of the geriatrics department was very impressive. So it was easy to pick on that and see the alignment with excellence in care, quality, and most importantly, I think, personalized safety, which is where this effort now is housed, basically. And the other part is that partnership, which I think we're going to talk more about with the board and Sean. And since Sean has been the chair of our board, we must prioritize quality and safety within all our meetings. And so the three levels, I think, of leadership that you're seeing here have been in great partnership to accelerate this work. And I think that's what we're going to talk more about today. So I'm excited to share more about that. Sean, I don't know if you want to make any additional comments.
Yeah, I'll just add to that a little bit that one of the things that we really have prioritized is we set the expectation and also the education of the board that this is really important and that safety and quality and age-friendly integration is there for us to hit these key metrics that we talk about constantly. And so what we've done at the board level is really put safety and quality right up front, and that's part of kind of my background. We'll talk more about that too. But we have safety and quality committee meetings right before a board meeting, and the first report out is safety and quality. And as I said, that's integrated with age-friendly care and kind of care models in general. That's integration and that culture, and making sure that everybody at the board understands that when Jose comes out with his quality and safety metrics and how important that is, we're not going to be able to hit any of those metrics unless we address that age friendly treatment.
Well, that's really so important. And Sean, since you've been chatting, I think I'm going to ask you a question. We've had conversations about your background and some of the influence that has had over how you perceive the patient safety, quality, and aging and age-friendly as a model for how we do patient safety and quality and how Hackensack does that. Can you share a little bit about your background and how that influenced your decision making and the way you perceive and look at this whole area?
Well, in some ways, I think what we do at Hackensack Meridian is really just a continuation of my career, which has started off as an engineer in the industrial sector, where we always called safety and quality, health, safety, security, and environment, HSSE. And every meeting starts with a review of HSSE and and what's going on with regards to incidents and reporting, and that's been critical, and that's been 35 years of my life. That's been number one. And if we don't start that meeting reviewing that, well, then we're going to fix that. And so I've been in their organizations and been in terms of governance and director of boards and vice chairman of Kuwait Energy, and coming into an ethic where it wasn't really safety oriented and quality oriented, and saying, hey, we're gonna put this right at the front of the board meeting, and really we started to make big changes over there. And so with regards to coming to Hackensack, it was already there, and certainly Jose joining a few years ago made the emphasis and the focus even greater. But it is really about kind of setting those standards and really emphasizing to the board, you got to pay attention to these things, and we're going to look at these before every meeting and in every meeting.
Yeah, Sean, I think that is so important. And, I'm also a nurse, but many, many years ago, when I was the senior vice president for quality for our healthcare system, we also had an engineer that we worked with. And it really gave me a whole different perspective on quality. And, when you think back about the fundamentals and the basics, if you go back to like Donna Bedian, who talks about structure plus process equals outcome, and how you can't get to the outcome you want without the structural pieces, the people, the equipment, all of those kinds of things. And then the process, which we seem to be really good at, right? Sometimes we forget those structure pieces, but to get to those outcomes, it's so important. So I really love you calling out your background, because I think we can learn a lot from engineering and putting that together with patient safety and getting the healthcare outcomes we're really looking for.
Yeah, and I think the early understanding and realization again that like paying attention to safety and quality leads to great operations and efficient operations and productive operations, which lead to great financial outcomes. And that's
right.
and once you see that linkage, you can never go back, really.
Yeah, exactly. And to great patient satisfaction.
Exactly.
And that's the other piece of it is really important. Jose, I want to take this a little bit bigger if we can for a minute. And in your role, really, I think frequently those positions are responsible for setting the culture and to really making sure that it isn't a one-off kind of thing in an organization, that it really is a culture and the way people live and the way people do things. Can you talk a little bit about how you think about culture and what you've done, and then maybe Mary Jo can talk a little bit about how she sees that culture as she goes to implement. So go ahead.
Yeah, sure. And Maria, I want to build on what you just said in terms of structure and process leads to outcomes, but maybe expanding that a little bit more, because in addition to structure and process, you have to have the right mindset, which is the culture part, and supplementing that with, you talked about engineering. We're very committed to a human factors engineering approach that takes into account how humans behave. This applies, I think, anywhere, but specifically in healthcare. We're a human-centered business, and unless we learn how to engage the humans on both sides of the process, right, the caregiver and the care provider and the person receiving care, we need to understand their mindset. We need to understand their attitudes and beliefs, and we need to understand also how to engage them in certain behavior change, so that we can be most effective. That also includes the way the partnership works between the board, the C-suite, and the improvement teams or the implementation teams. So I'll just give a couple examples. In terms of our approach, we call it the agile transformation approach here. And basically, the governance comes from the board, right, in partnership with the C-suite. So I still remember when I came here and Sean took his role as chair of the board, we went out for lunch and we dreamt big. And in that relationship, also prioritizing quality and safety as the first report sends a different type of message that really shapes our minds differently, the board's mind, the C-suite mind, right? So operations, finance, and quality are really seeing through the lens of governance how important it is to ensure that our patients receive best care, right? And that this is the top priority. So that shapes our mind differently, our priorities differently, and the way we interact differently. The other part is also committing to making the right decisions at the right level. So we standardize or we determine the direction from the network or the system level under the guidance of the governance body. But then we allow for localization. We allow for local implementation. We have 18 hospitals across the network. We have 500 ambulatory sites. They're all different. They have different resources. They serve different communities. They have different needs. They also have a different set of structures. So how do you adapt to all that variation? You have to localize within some level of central standardization. So typically what we standardize from the system is the why and the what. Mm-hmm. And that we allow for local variation within the why and the what in terms of how do we meet what needs to be there or what is the standard and by whom, right? So if we agree that we need to do ambulation, for example, which Mary Jo can speak more in details about that, we're not determining exactly how every hospital is going to ambulate patients. We're determining what is expected, how often are patients expected to be ambulated, and what is expected out of an ambulation process. And then we engage with the local sites to basically engage them both emotionally and intellectually in figuring out how to meet those standards. So Mary Jo, if you wanted to speak more about the implementation side, but that partnership at the three levels, the deciding the why and the direction from the governance, deciding what are the essential standards across the network that apply everywhere, and then localizing that in a way that makes the implementation more efficient and more effective. Mary Jo?
Yeah, thanks, Sean. Or thank you, Jose. So what I was going to say is I think Sean and the board really set the standard there, or they set the vision there. And then Jose and the team, to bring in another agile principle, really helped me bring to the forefront of the staff the demand. So there is a real demand across all of our healthcare systems to look for the best evidence to care for our older adults. So for the first time in our country's history, right, our older adults are going to outnumber our number of adolescents. So this is something we can't ignore. And Sean made that comment, but I think too that link to readmissions, length of stay. After this webinar, everyone's going to receive some publications, including a link to the quadruple aim. But Sean said it differently, but I'm going to say it. I say to people, you can't unsee it. You can't unsee how when you are implementing the best evidence, that you are then able to really move the needle and the trajectory. So I think some of the other pieces, so Jose talked a little bit about how, you know, our minimum standard and then how folks are going to go ahead and operationalize. One of the other things in finding out with our Joint Commission Health Equity Certification is that we had several areas that were identified. The older adult was identified as being a priority area. Being able to take this evidence to those teams and say to them, we have the evidence to support what you need to do. Now let's brainstorm how we can do it. Jose brought up a little bit about mobility, but one of the other areas that we're working, we're kind of changing some things around in mobility. We have a mobility assessment embedded in our fall risk assessment, but we may be looking to parse that out, right? We use the BMAT, but replace that with maybe the AMPAC. Just a lot of great data on that with being able to really push the discharge to home. And then other areas that I know a lot of people have questions about, which is the geriatric prescribing context, and really just changing the workflow for our clinicians to be able to say, we have the answer of how you can make sure that you are prescribing safely. We're going to embed that in your workflow, and we're going to make sure that it's not disruptive. It doesn't create alert fatigue. Again, just saying, we know what the minimum is, and now we're going to go ahead and implement evidence in ways that are going to help you.
So Mary Jo, it makes me think that, you know, as people consider how they want to do this in their organization, you said a couple really important things. And one was connecting to the strategic plan or the focus and the priorities in the organization. The other side of that, I always think about those at the bedside providing care and doing the work of this. The 4Ms are structured in order to be care processes that already exist, right? That we just kind of tweak. But can you talk a little bit about how you think about or deal with that sort of caregiver burden that doing something like this at this scale and this level, how do you think about that caregiver burden, and what are the things you've done to sort of mitigate that as you can?
So two things. I do want to just say again what you said, that this is a framework, right? We're not trying to offload additional work on individuals. What we're saying is we want you to think about all of these things every time you're caring for the older adult, but chances are you're already doing that. What I have found really fun about my work with the 4Ms is that once you have to look at two components of each M, the assessed piece and then the acted on piece. And once we start quantifying, and that's really where, you know, the board intersect as well as the quality and safety team comes in, is because any barriers we have with getting access to data, building reports or prioritizing reports, right, comes from them. And once we're able to really quantify those numbers, we know where we need to move the needle. Mm-hmm. And then I get to go back to the front line and say, this is what we need to do. What ideas do we have? Let's scour the evidence. Let's look. Let's talk to other organizations. The system-wide collaborative we're in right now is fantastic, but let's talk to other organizations. We're all in the same boat. What can we do? And I did touch a little bit on the geriatric prescribing context. And I will just say very briefly about that. When we first went to our DTS team, we said, we have the greatest idea. What we're going to do is we're going to have alert pop up every single time there's a medication that is potentially inappropriate for our older adults. And they all looked at us and said, no, you're not. We have a huge initiative in our organization to dump the junk and to really omit any type of alerts that are coming and disrupting that workflow for the provider. So my pharmacist and I said, this is fantastic. We know exactly what we're going to do. We're going to build this passive sidebar summary, and it's going to give information to all these different groups, and everyone's going to read it. Well, we had no change in practice there. So it wasn't until we read the publications by Dr. Drago and realized, and team there at OSU, that we should really implement something that is embedded in the clinician workflow. So very similar to the pediatric prescribing context, what we do is we just offer up the right doses and the right frequencies. Providers can override it, but very similar to pediatrics, it's almost giving, we said just recently, we were all talking and we said, when we go to dose pediatric patients, we double, triple, quadruple check. Sometimes we call pharmacy for verification.
Right.
And we want our team to be in that same spot with older adults too. So just making that workflow that does not allow for alert fatigue that I was denied, and embedding it has been so helpful, and it really has moved the needle on our frequencies and dosages prescribed.
That's awesome. And Jose, go right ahead.
Make a couple comments here, because I think Mary Jo highlighted a few really important aspects of this approach, which is really involving all the stakeholders, because we all have our different perspectives that are essential to a successful solution, right? And it's in that tension between all the different perspectives that we come up with the best solution. And I think sometimes we look at the expert in the content, but we forget about the expert in the context, or the expert in certain boundaries, right? So if you listen to what Mary Jo is speaking about, the bedside teams are the experts in the context. They understand what works and what doesn't work in their workflow, right? Mary Jo and her team are the experts in the content, but then you have the IT team, what we call DTS. The IT team, they're the experts in the boundaries. What are we not willing to tolerate, right?
Yeah.
Or what are we? And so, unless you bring all together to co-design a solution, you're going to be coming up with solutions that cannot be executed effectively. And I think this is where that interaction and the support in terms of prioritizing certain things, breaking certain barriers, but then sometimes you have to actually push back and maybe accept certain barriers, right? So instead of breaking the barrier of, yes, it's okay, we want to add alerts because it makes it easier, right? And then burden the bedside teams. That is one of our principles. We don't want to add the burden. We want to reduce the burden, right? The barrier that we broke was, that this project takes precedence maybe over other dashboards that we're developing. So we escalated that. So I think it takes everybody to be on a level playing field and respect each other's expertise, so that we can come up with the best solution.
That's excellent, really. Sean?
Yeah, I'll just kind of take it from a higher level, and really all the way back to when Hackensack and Meridian merged, 9 years ago, a little over 9 years ago, and culture was number one. John Lloyd and Robert Garrett, who's the CEO today, it was really a focus on culture, and that culture, just seeps down through everything that we do. And when you think about age-friendly care and integration into standards of care, that becomes a cultural part. And so we, as Jose and Mary Jo have outlined very well, like it almost it is becoming just what happens on a daily basis.
Mm-hmm.
And then so, from the governance perspective, we look down, at that and see the success of all that, and say that's part of the theme of culture that started from the very, very beginning. And that if you don't embed it in the culture, it probably isn't very effective, or it's very hard to get it done. But I just very happy that we've been really focused on that from the very, very beginning. As we said, this has started to become the standard of care, which is just totally integrated with age friend, what you would call it, all the 4 M's fit into that standard of care on a daily basis.
That's really amazing. I have one more question that I want to ask the group, and then I see we have a couple of questions in the chat, so I want to give time to do that. But when we met at our AHA annual meeting, one of the things that came up from the audience was the role of the CFO in initiatives like this. And we know that for Age Friendly, there is a document that helps teams develop the ROI, or return on investment, as they're starting to think about this. But could you help me understand a little bit, how involved is your CFO, and what kinds of things each of you have dealt with from the perspective of financial perspective and financial goals and objectives? And then I'm going to add this, and you can answer it together just because of time. One of the ways some people get to do this is through funding. So just also, if somebody can just address what you've done as far as any funding, whether you've got funding, but it's around that financial perspective, if you will.
Let me jump on the CFO piece real quick, and then maybe Mary Jo can speak to the funding. I'm very, very fortunate that I have a CFO who truly understands the mission. But I also want to say that the fact that the board, under Sean's leadership, has prioritized and elevated quality as the first report before finance sends a clear message to all the executives that, right, our quality outcomes, our safety outcomes, delivering excellence in care is our mission, right? And therefore, I'm fortunate because our CFO always speaks to, and he makes all our clinicians fall off their chairs when he says that, but his only purpose is to finance our initiatives so that we can deliver best care, right? And I think that's a unique type of CFO, but we're very fortunate to have him. And that has allowed us to support the effort. The other part is creating alignment, I think, right? So when we look at the initiatives that Mary Jo and many in the geriatrics collaborative and division have done, we've aligned that with our patient safety priorities, right? Because we look at this as a safety initiative. That has really aligned resources. So I don't have to duplicate resources, because by working on Age Friendly, I'm reducing mortality, I'm improving length of stay, I'm improving readmissions, and I'm providing better care for our aging population, which is a big portion of the people who unfortunately end up dying in the hospital or get readmitted. And so by aligning those initiatives, I'm not duplicating resources, I'm aligning resources, and therefore it makes it more financially sustainable.
So I'm going to interrupt for 1 minute, and Jose, I'm going to add a question from the chat onto that. And Mary Jo, this is probably for you as well. Talk about tactics or strategies you've used to get buy-in from the medical staff, and how you have engaged the medical staff in this initiative and in this culture change as well.
Yeah, so I'll start there. So I just want to talk about funding real quick. The one grant that I know we have is an IHI seed grant that we received to do screenings for swallowing difficulty in the emergency department on any older adult, 65 and older. So I'm really looking forward to seeing what comes of that. But tactics to secure buy-in really have to do with having folks explain what their goals are. Like, I can use GSV, for example, the Geriatric Surgical Verification Program. Those surgeons at our 2 flagship facilities are extremely dedicated to getting this program. So when we come to them and we explain what the 4 M's are and how, if we do all these things in unison, we can get them that certification, we can give them the evidence that they need, they see that intersect, and then they're so willing to work with us. So we have great calls. We've also created a really great governance structure overseen by our 2 geriatricians from the different hospitals. All these teams report in the GSV, the emergency department, geriatric accreditation. We all come together, and not to tell each other what to do, but just so that everybody's in the know of what's happening in all these departments. Because what we're seeing is that there's so much intersect. So instead of us needing tactics, it's almost like, wow, I can't believe you're doing that. We need to do that too. So for example, what matters, right? Before surgery, major events, we also need to do that across the network. So that's been exciting.
That's awesome.
And Marie,
Yeah.
and I might repeat myself, but once goes back to the CFO, once you realize and see that linkage, which you can't help but see, the linkage between good operations, age-friendly care ties into health, to safety and quality, leads to good operations, efficient operations, leads to good financial outcomes. Well, then he's very happy to pay it, and to fund it.
Right.
So,
Right.
like once you see that happening,
Yeah.
it's kind of obvious.
That's awesome. Yeah, that's great. So we have hit time here. Thank you so much. This has been a great conversation, and you all know me. I could go and keep going with this. We will follow up with any question that got sent in the chat that we didn't get to answer, and I think there might just be one. So we did a good job on this. We kind of hit on them as we were talking. So thank you all for joining and participating, and to the folks from Hackensack Meridian Health, thank you so much, not just for being with us today, but for the good work you're doing and for prioritizing this, for making age-friendly care a part of patient safety. I think that that's the way we can go forward with the increasing numbers, as I am one of them. I'm really grateful to see organizations who are really looking at this and moving toward providing age-friendly patient safety, all as a combination for a model of care. So thank you all very much. I look forward to having more conversations with you as the work goes on. And thank you to everyone who joined us today and participated. Please reach out if you have other questions to the AHA team. We'd be happy to get answers for you, or connect people. And we really appreciate all of your work. Thank you.
Thanks,
Thank you.
Marie.
Thanks for having us.